A very good morning to one and all. The topic for discussion now is sleeve surgery and liver transplant, indications, feasibility, and outcomes. So, as we all know, morbid obesity is a fast-growing pandemic. MAFLD and MASH have become a growing cause of end-stage liver disease and are now the second most common indication for liver transplant in the West. Not only is it a cause of end-stage liver disease by itself, it also accelerates other causes of liver damage. According to the OPTN 2017 database, currently close to 40% of liver transplant recipients are obese and nearly 15% have morbid obesity. So though it can be an indication for liver transplant, however, morbid obesity is also a barrier to accessibility to transplant and results in poor transplant outcomes. Obesity post-transplant worsens because of the effects of immunosuppressive medication as well as a sedentary lifestyle. Recurrence of MASH in the transplanted liver has been reported from up to 8% to 100% of patients depending upon the duration of follow-up. It's also an important cause of long-term mortality as critical care continues to improve and we better understand these patients. Graft failure as a cause of long-term mortality is reducing and cardiovascular events are increasing. So obesity has consequences both preoperatively at the time of listing, perioperatively, and in the long run. So it results in increased wastage mortality, increased portal vein thrombosis, perioperative complications, prolonged ICU and hospital stay, recurrence of NASH, worsening or de novo onset of metabolic syndrome, as well as HCC recurrence in these patients. And while medical ways of reducing weight are the first step, non-invasive measures are the first step to losing weight, bariatric surgery is being increasingly recognized as an important tool at all these time points, that is before, during, and after. So the indications for adding a bariatric surgery to your liver transplant program would remain the same as that in the non-transplant recipients. So a BMI that is more than 35 in the presence of comorbidities or a BMI more than 40 in patients who have been unable to lose weight medically. So now when we talk about bariatric surgery or sleeve gastrectomy in the context of transplant, we are looking at two important aspects. One is what is the safety and feasibility of this procedure, and second, what are the long-term outcomes, especially in terms of graft survival and complications. So first we'll look at pre-transplant bariatric surgery. So we know that any amount of weight loss is going to cause some improvement in the liver histology, and the goal of pre-transplant bariatric surgery is to reduce BMI in order to improve transplant eligibility as well as improve the post-transplant outcomes. However, what we are dealing with are cirrhotics who have got a diseased liver. A significant proportion of them would have decompensated, and therefore there are important considerations in terms of your MEL status, child status, the preoperative bilirubin levels, INR, presence of coagulopathy, which will all go into the decision making regarding eligibility for bariatric surgery in this subgroup. Secondly, these patients are going to be at a very high risk of decompensating post-procedure. Second, the complications of bariatric surgery itself in the long run result in precluding transplant for these patients. There are no guidelines that help us advise what is the type of surgery that should be used, but what we do know is that the risk of complications is prohibitively high in patients who are actively decompensated, and so this subgroup should be excluded. Similarly, patients with severe portal hypertension should probably be excluded from a pre-transplant bariatric surgery. So even though the topic itself starts off with sleeve gastrectomy, I would just like to tell you a couple of points. Bariatric surgery encompasses several forms of surgeries like Roux-en-Y gastric bypass, mini gastric bypass. But sleeve gastrectomy is the one which has been chosen and has been where most of the data lies, and this is because sleeve gastrectomy is essentially a restrictive procedure. So you're removing 60 to 75% of the stomach, but you're not altering the anatomy. So in these patients who are transplant candidates, endoscopic access to the biliary tree in case of any complications is maintained. Secondly, since it's only restrictive, the malabsorptive component is not there, your immunosuppression levels are not going to go haywire. Third, it's it's a rather simpler procedure, shorter operative time, so patients are most likely to withstand this procedure compared to the other procedures, and it's also faster. So when the BMI reduces following bariatric surgery, the advantages are that there is, when you lose more than 10% of body weight, there's regression of fibrosis. So data suggests that up to 20% of patients can get delisted after bariatric surgery once their LFTs improve. So it ameliorates obesity-associated medical conditions, so there is reduced perioperative risk also. There's improvement in your wound complications in the short term, lower risk of recurrent NASH in the transplanted liver, and lesser metabolic sequelae. However, it doesn't come with its issues. So once you have done a bariatric surgery, you're going to have to postpone the transplant for a certain period of time till you can achieve the adequate metabolic response. Second, if there are complications of bariatric surgery that need to be addressed before the patient can be transplanted, and sometimes these complications can preclude transplant by itself. So finally, it appears that this is feasible in only a very small select subgroup of patients. But then what are the results in these patients? So this is data from the University of California. So what they did is they looked at 32 patients who underwent pre-transplant sleeve gastrectomy. So you see the MELD is 12. So these were all patients who had decompensated in the past, but at the time of the procedure, they were all compensated. The MELD was 12. Of all these patients, only one patient had a major morbidity in the form of gastric leak. However, this patient could therefore not undergo LT following this. The amount of excess body weight lost was close to 50% at 1 year. Interestingly, 7 patients were deferred listing because of improvement in their liver functions, and 2 patients who were listed and awaiting transplant got delisted because of improvement in their liver functions, and these include 2 patients who were child B at the time of listing. So we see that close to a third of patients, because of bariatric surgery, could be taken off the list. So they concluded the potential of sleeve gastrectomy in morbidly obese patients with advanced liver disease who might otherwise not be eligible for transplant is feasible, and in appropriately selected patients it's technically feasible, accepted complication rates, and significant and sustained weight loss is there. The same group then went on to report its results, comparing them with patients who had lost weight medically and then gone on to transplantation versus those who underwent bariatric and then went on to transplantation. So between 2006 to 16, they had 14 patients who had undergone sleeve gastrectomy undergoing transplant, compared with 56 patients at the same time who underwent medical weight loss. Their mean follow-up was 5 years. Now here they talk about their inclusion criteria. So you see all the patients that they included for sleeve gastrectomy are those who are either child A or B. And while they have included MELD less than 20, none of their patients actually had a MELD more than 14 at the time of listing. The INR was less than 2.5. Exclusion criteria were hypoalbuminemia, thrombocytopenia, ascites that is not controlled, or HE, or hepatopulmonary syndrome, or portopulmonary hypertension. So all patients were put on a medically supervised weight loss program. Those who failed to lose weight were then subjected to sleeve gastrectomy. So these two groups at the time of comparison were similar, excepting that the group in sleeve gastrectomy had a baseline BMI which was significantly higher at 44 compared to 39 in the medical weight loss group. Now we see how these patients fare. So if you look at, we saw that they started off with 44 versus 39, but at the time of transplant, their BMIs were comparable at 33.8 and 35. In fact, if you see, it has come down from 44 to 33.8 and from 39 to 35.7. And even though these are not statistically very different, though it is lower in the sleeve gastrectomy arm, but the fall is much more in the sleeve gastrectomy arm. So there was no other statistically significant difference. Even in terms of perioperative outcomes, the ICU stay was lesser in the patients who had undergone a sleeve gastrectomy, obviously because of weight loss benefits. But their blood loss and other perioperative complications were similar, despite the sleeve gastrectomy patients having undergone one previous surgery, that is sleeve gastrectomy. Interestingly, even the rates of extubation, though not statistically significant, were more in the patients who underwent a sleeve gastrectomy. All-cause mortality and hospital stay was not any different in the two groups. If you look at the patterns of the weight loss, you see that the BMI fell in both the groups, that is the weight loss, medical weight loss, as well as sleeve gastrectomy by about 3 months, which alludes to the catabolic phase following a major surgery like liver transplant. But as time passed, the medical weight loss group regained all the weight, and by 4 years they were back to their pre-transplant listing weight, whereas the weight continued to fall in the subgroup of patients who underwent a sleeve gastrectomy. And the percentage total weight loss was also 40% at 4 years compared to only 0.8% where in the medical weight loss group, where the weight started climbing back again. If we look at the predictors of de novo or progressive diabetes or recurrent or de novo NAFLD in these patients, so we see that pre-transplant sleeve gastrectomy is a protective factor for both diabetes and fatty liver, and pre-transplant diabetes is a risk factor for development of diabetes or NAFLD in the transplanted liver. So the authors concluded that when compared to medical weight loss, sleeve gastrectomy resulted in sustained weight loss and significantly lower risk of diabetes, hypertension, and recurrent and de novo NAFLD post-transplant. This is a small series of patients who underwent sleeve gastrectomy prior to transplant. So we can see that in the initial phase, the complications are very high as compared to this group, which has the largest data, which has a 10% complication rate. But the excess weight loss is upward of 50% by 6 months to an year. And by 6 months to an year, almost all these patients are again eligible for transplant. The comorbidity is resolved in most of the patients. However, not all patients would be candidates for a pre-LT bariatric procedure because a substantial proportion would be decompensated. So with this, simultaneous sleeve gastrectomy in the setting of liver transplant was proposed. It was first reported from the Mayo Clinic in 2013. We have the first report from India from it is a case report from Dr. Vinay Kumran's group in 2017 in the setting of living donor liver transplantation. The advantages are obviously you're subjecting these sick patients to a single intervention. There's going to be a single recovery phase. Once the new liver is put in place, there is lesser problem with portal hypertension related complications that we would face in the pre-LT bariatric group. This is going to have a beneficial impact on the graft and the patient survival and reduction of obesity related complications. However, the issues are that you are going to subject these patients to two major procedures. It may be in the same setting, which makes the surgery even more formidable, and they are going to have the complications of both the procedures in their post-operative period. And then even though you may plan to do a sleeve gastrectomy in the same setting as LT, if the patient is hemodynamically unstable, as a lot of these patients are by the end of the hepatic artery anastomosis, these patients may not proceed with the sleeve gastrectomy as planned. So this is the first report that came from the Mayo Clinic. 37 patients evaluated, 30 lost their weight medically, 7 patients failed to lose, and they were subjected to a combined sleeve gastrectomy and transplantation. There was 0 mortality. 1 patient had a leak and 1 patient had excess weight loss. mean BMI fell from 48 to 29. So they concluded that non-invasive weight loss, if you see out of 37 patients, 30 patients, that is 3/4 of the patients did achieve. But the problem is that there's a weight gain post-LT. Then combined LT plus sleeve gastrectomy resulted in effective weight loss and was associated with fewer post-LT metabolic complications, and this study established the feasibility of such a scenario. There's another small study coming from the Mayo Clinic in Florida where 10 patients underwent a sleeve gastrectomy simultaneous with the liver transplant. So you see the pre-transplant mean BMI was 43, and at 6 months it had reduced to 30.6. Their average lengths of stay were similar to those without, that is at 10 days. Very few complications, and none of these were attributable to the sleeve gastrectomy per se. The excess weight loss at about 1 year was 66%, and they concluded that simultaneous liver transplant and sleeve gastrectomy are feasible, safe, and do not add risks or adverse events to regular liver transplant surgery and effectively reduce body weight and control comorbidities. However, a lot of these patients will, as we have seen, may not be stable by the end of the implantation and the hepatic arterial anastomosis. So this group from Houston pioneered a 2-stage approach in liver transplant. So they first reported the results with a 2-stage in SLKT, where they transplanted the kidney on the first day following the liver transplant and reported better graft outcomes. So then they extended it to the other liver transplant patients where they are undergoing liver transplant alone, and they do a delayed biliary reconstruction. So after the arterial anastomosis, the patient is closed, shifted to the ICU where the patient is optimized, and as the liver function kicks in, the lactates clear, patients become better. And then in the second stage, so these are patients where you have a doubt of hemostasis and you think it works like a second look surgery for these patients, where you feel that these patients would probably end up having a re-exploration if you were to do everything in the same sitting and close. So in a span of 2 years, they compared. So following this, they decided that this was the second stage of the procedure was a good opportunity for them to add on sleeve gastrectomy in patients who are morbidly obese. And so they proposed early sequential liver transplant with sleeve gastrectomy as a 2-stage approach, and compared it with controls who during the same period had undergone transplant as a 2-stage approach but without the sleeve gastrectomy. So they had 14 patients in the 2-stage transplant with sleeve gastrectomy arm and 28 patients who had undergone transplant without sleeve gastrectomy. So the important thing is that this 2-stage approach had been their standard protocol prior to them adding the sleeve gastrectomy also, and this was not done for the sake of sleeve gastrectomy. So if we look at their patient parameters, so obviously the BMI of patients who underwent a simultaneous sleeve was much higher, 47 compared to 38. But what's interesting is if you look at their MELD scores, so MELD scores are close to 33, and more than half their patients were on either mechanical ventilation, vasopressors, or CRRT at the time of transplant. So they are dealing with a much sicker subgroup of patients than what we have seen in the previous studies. So in this subgroup, so they in this showed that when you go on to the second stage, there's a substantial decrease in the vasopressor requirement, substantial improvement in the lactate levels, improvement in the INR levels, and reduction in the transfusion requirements during the second procedure. So this validated their approach, that a two-stage approach was probably good in this set of patients, and was a feasible approach even in these sick patients. At 1 year, the graft survival was not significantly different between the cases and controls. They behaved same when you look at the unplanned re-explorations within the first 30 days, or ICU stays, or overall post-transplant hospital stays. If you look at the BMI and the weight, so we saw that they started off with a BMI of 48 versus 39, but 38. But though this was significantly different, by 6 months itself, and thereafter maintained at 1 year, there was no significant difference in their BMIs, which means that the cases got much more weight compared to the controls. The same thing holds good for the weight also. And if you look at the percentage total weight loss, it was much more in the cases even at 1 year post-transplant compared to the controls. So this was basically a proof of concept study that such a two-stage protocol, brief staging approach, could be used to allow even these sicker patients to access a simultaneous sleeve gastrectomy during the liver transplant. And this resulted in sustained weight loss at 1 year with similar graft survival. However, what we have to remember is that this stage protocol is not something that has been reported by other centers. And outside of the center, we don't have much data from this particular approach. However, not all centers have been giving us this good results. So these are, so while most of the data has come from US, this study, the LTSG study, was published in liver transplantation this year. It provided a European perspective. So 11 adults listed between 16 and 22. And so they also gave a strict exclusion criteria, that is patients who are elderly or patients who had contraindications to bariatric procedures like severe GERD, Barrett's, psychiatric illness, previous bariatric surgery or upper GI surgery. Intraoperatively also, they had kept their exclusions, that a patient who ends up requiring more than 10 RBCs or patients who have a moderate to severe reperfusion syndrome, they would not go ahead and do a sleeve gastrectomy in this subgroup of patients. So they found that out of their 11 patients, 30-day mortality was seen in 4 patients, 36%. One sepsis, the other was PNF, HAT, and ARDS. They had a 36-month follow-up, and that showed good graft function in the survivors. The hospital stay was about 13 days. But if you look at the 30 and 90-day overall survival was 60% and 54%, which is not very encouraging overall. And if you look at the outcomes, you see that so this is a very small subgroup, and you have only 6 patients remaining for a long-term follow-up. And in these, by the end of 3 years, 75% of patients have weight recidivism. So their obesity comes back. Along with the obesity, the metabolic syndrome, the complications, hypertension, triglyceridemias, diabetes, everything does make a comeback. So this is the first study that has shown us that even though you could attain weight loss in the immediate perioperative period, this may not last in the longer run. And these results of sleeve gastrectomy have also been similarly reported outside the ambit of liver transplant, that most of the bariatric procedures will not give you sustained weight loss in the long run in a substantial proportion of patients. So considering that they had a significantly high mortality, they also found out predictors of mortality when you are subjecting patients to simultaneous transplant and sleeve gastrectomy, and they found that the pre-allocation survival outcomes following transplantation score of more than 15 was a predictor of mortality, as well as anybody who has 3 of the following, that is age more than 60 years, a high BMI more than 45, metabolic syndrome, MELD more than 25, or a donor risk index of 1.6. So they concluded that in severely obese patients, simultaneous sleeve gastrectomy with LT is a highly complex procedure that can carry excess risk in certain situations, and the prospect of weight loss and metabolic control is not maintained in the long run, and it should be considered only highly selective patients. So now what is also important about this study is that a lot of the donors in this were extended criteria donors. So probably the graft that they got was also not a very good graft, apart from having a high melt also. So this could have been responsible for the in general poor perioperative outcomes in this subgroup of patients. The Mayo Clinic published its consolidated results from all the 3 centers in the recent edition of JHEP in 2025 in June. So they compared 72 patients who underwent simultaneous sleeve and liver transplant with 185 patients of MASH who had a BMI of more than 30 and underwent liver transplant alone. So what we see is obviously the mean BMI in the simultaneous cohort was much higher at about 45 compared to 34, but other parameters were similar, excepting for a younger age in these patients who underwent a simultaneous sleeve and the shorter follow-up in these patients who have undergone a sleeve compared to the transplant alone. If we look at the overall and graft survivors, these are similar. If you look at the BMI change, so the patients who had a simultaneous sleeve were able to have maintained their lower BMIs much more compared to those who were subjected to transplant alone, where the BMI increased post-operatively. Similarly, the proportion of patients with diabetes fell in the post-operative period in the simultaneous sleeve group, whereas it increased in the group following only LT, and this was also statistically significant. There was a significant number of patients with the probability of steatosis being more in those subjected to transplant alone, as also the probability of cardiac events being more in those who are subjected to transplant alone, alluding to long-term benefits of the sleeve gastrectomy. And if you look at metabolic syndrome, so patients who underwent simultaneous sleeve had a decrease in the levels of their diabetes, hypertension and hyperlipidemia following the sleeve gastrectomy. They also assessed fibrosis using MR elastography, and though this was not statistically significant, a greater proportion of patients did not have fibrosis in the simultaneous sleeve subgroup. So the authors concluded that the simultaneous transplant and sleeve gastrectomy results in a sustained weight loss, resolution of diabetes and hypertension, and reduced recurrence of steatosis, and possibly compared to LT alone, and confers no increase in mortality or graft loss. So what I would also like you to see is that these are all almost close to 8 to 10 years of follow-up this paper is showing us, which is in contrast to what the European study alluded to. So there seems to be some dichotomy whether these results are durable or not, and we need more data before we can say the benefits will be there in the long run also, but perioperative benefits are there, no doubt. So this is a summary of a few of these studies, but what is important here is that you see most of the data comes from US and from a handful of centers. So this is the Mayo Clinic, which contributes, so this 2013 paper, this 18 paper, and this 22 paper, they're all papers from Mayo Clinic. So all large studies have come from Mayo Clinic. This study of 49 patients is just this is a database study which basically has duplication of patients from these other studies. But what it does show is that at varying periods of follow-up, there's a significant BMI decrease, and percentage of total weight loss or excess weight loss is significant in these patients who undergo a simultaneous sleeve gastrectomy. But then all patients who are decompensated and who are undergoing a transplant may not be fit enough to be able to undergo a sleeve gastrectomy at the same sitting because of varying reasons like either hemodynamic instability, or the patients may secondarily gain weight during the post-transplant period because of the effect of immunosuppressive medication. So when we talk about the feasibility of sleeve gastrectomy post-LT, so it's a very technically challenging condition. So these are patients who have had a major procedure, so you're going to have post-operative adhesions. The patients are already on immunosuppression, and this is going to have implications in terms of wound healing, and especially in terms of leaks and how they respond to sepsis. The patients who may be candidates for post-LT sleeve gastrectomy may not get offered sleeve because they may be still struggling with their post-LT complications or immunosuppression regimens, etc. The advantages in this setting are that now that you have a new liver in place, a lot of portal hypertension has abated, which was not there in the pre-LT scenario. These patients are hemodynamically stable, elective patients that you are taking up. And this is the only way to address post-transplant weight gain. However, what we have to recognize is that, again, most of the literature is in the form of very small case series. So this is one of the larger experiences of about 15 patients operated between 14 and 18. So the median time between transplant and the gastrectomy was about 2.2 years, and they were followed up for another 2.5 years. So they showed that the median length of hospital stay following the sleeve gastrectomy in this subgroup of patients was 2 days. There was 0 mortality, 0 rates of liver allograft dysfunction, and post-operative complication was seen in only 1 patient. So rather optimistic data. So we look at this. So between the, if they saw that patients' BMI reduced significantly after a laparoscopic sleeve gastrectomy, and the amount of insulin requirement also decreased drastically between the pre-sleeve gastrectomy and post-sleeve gastrectomy. And when they went and compared patients who had undergone a post-transplant sleeve gastrectomy with the non-transplant sleeve gastrectomies, they found that other than the fact that the blood loss was marginally, statistically higher, but obviously not clinically significant between 50 ml and 5 ml. There weren't any significant differences in these two subgroups in terms of their perioperative outcomes. So they concluded that this is following liver transplant is safe, effective, and does not increase the incidence of liver allograft rejection. However, like I said, most of the literature is very small, limited, and experiences are varied. So in this particular study from experience from Daniel Azule's group, they found that of the 6 patients who were offered sleeve gastrectomy following transplant, 3 were offered laparoscopic sleeve gastrectomy and 3 were offered open because they had to undergo an incisional hernia repair simultaneously. So there was 1 late mortality out of 6 because of gastric fistula. 1 patient developed a chronic mesh infection. The median follow-up period was close to 4 years, and the median length of post-operative stay was about 9 days in these patients. So they concluded that while it is technically feasible and results in a weight loss without adversely affecting the graft function and immunosuppression, but the morbidity and mortality is much higher in this subgroup compared to the pre-non-LT sleeve gastrectomy group or other subgroups. So this is again Mayo Clinic's experience, where they've compared their results before, during, and after solid organ transplantation. So here they have included all kinds of organ transplants, including liver, heart, lung, kidney, and they concluded that it was safe and resulted in improvement in the obesity related complications and improved the patient survival. So this is a meta-analysis that looked at outcomes following bariatric surgery combined with the liver transplant in the pre-transplant, simultaneous, and the post-transplant group. So 24 studies included overall. Before transplant, 12 studies, 201 patients. The mean time between transplant and bariatric surgery ranged from 13 months to 16 years, and this is primarily because when we say pre-transplant, this includes all studies where patients who are undergoing transplant, anybody who's had a history of bariatric surgery have been included, whether or not they were actually decompensated or candidates for transplant at that time, and those who were actually candidates and then went on to receive bariatric surgery to make them more eligible. So they found that the early post-operative morbidity after bariatric surgery in patients with on the waiting list was 5%, which is significantly more than what you would expect in a non-cirrhotic population. But the prevalence of 1 year post-LT mortality at 7% was similar to what it is in the normal patients of undergoing LT. As far as the simultaneous subgroup was concerned, they had 5 studies with 81 patients, but the data was not subjected to meta-analysis because enough literature was not available on each point of complications or mortality was not available. This is the post-transplant studies. There were 9 studies with 71 patients. And the delay between transplant and bariatric surgery, again, the time period ranged from about 2 years to 6 years. And they found that the early post-operative morbidity after bariatric surgery in patients with a history of LT was 16%, which is significantly more than what you would expect following sleeve gastrectomy in normal subgroup of patients. So they concluded that it can be performed in selected subgroups in the setting of liver transplant. Simultaneous bariatric surgery and liver transplant are considered associated with low morbidity and mortality, while bariatric surgery after transplant has shown increased morbidity. Before LT is feasible and can improve liver function for patients in the transplant waiting list, but only a very small subgroup would be fit enough for it. So to summarize, bariatric surgery in liver transplant recipients, this is increasingly a need to assess the eligibility. So during the pre-transplant period, select group of patients may be eligible and where it may be safe to perform a sleeve gastrectomy. During transplant, reports have shown the feasibility with good long-term outcomes. But what we need to remember is that most of the data comes from a handful of centers, and all the papers that are talking about this are coming from the same centers. When it comes to post-transplant, obviously there's a higher risk of complications and there's a greater technical difficulty. Almost all the existing literature is actually in the setting of DDLT. It comes from the West, and like I already alluded to, it comes from very few centers. Now, there are newer drugs that are coming up which may change the paradigm of when we talk about what is non-invasive weight loss management, and therefore this can have an impact on, again, the time point at which bariatric surgery would need to be introduced to these patients. Long-term outcomes, very limited data on long-term outcomes. Conflicting data with some reporting weight recidivism. Persistence of weight loss in the long run is what is questionable. And finally, it is centers who have combined extensive transplant and bariatric experience which should take up these patients for either pre or intra or post-transplant bariatric surgery. Thank you.